Good morning. Today I'm discussing about disorders of nasal cavity. So, first one is bacterial rhinitis. Bacterial rhinitis it is observed in cats, rarely in dogs. So, it is caused by Bordetella bronchoseptica, Mycoplasma streptococcus equi zooepidemicus. They are also responsible for causing bacterial rhinitis. Bacterial rhinitis is a secondary problem whenever any primary disease disrupt the mucosal defenses. So it is due to some other problem. So antibiotic treatment is temporary. So you have to evaluate and treat the underlying disease. So uh, next, diagnosis of bacterial rhinitis is through clinical sign mucopurulent nasal discharge. Definitive diagnosis is difficult because of diverse flora of the in the nasal cavity. So, non-specific finding in bacterial rhinitis they are neutrophilic inflammation and bacteria. Because this in nasal cavity most of the uh, there is diverse microflora, so when you take nasal swab or mucosal biopsy specimen and you culture that, so growth is observed normally. But if there is growth of many colonies of only one or two organisms, that may represent significant infection. But if growth of many different organisms or small number of colonies, they represent normal flora. So microbiology lab should be requested to report all type of growths. If you suspect mycoplasma, then sample should be placed in appropriate transport media, right, for culture. Uh, if you beneficial response occurs to antibiotic, that is also supportive of your diagnosis of bacterial rhinitis. So this is a cytology of nasal swab. You can see the neutrophils, different type of neutrophils, and you can see intracellular bacteria inside the neutrophil. These are the RBCs. These are the RBCs, red blood cells. Then treatment of bacterial rhinitis, obviously bacterial. It is you can use antibiotic. Antibiotic should be selected based on culture sensitivity. If you suspect anaerobic bacteria, then you can use antibiotic accordingly that targets the anaerobic bacteria. You can use broad spectrum amoxicillin, clindamycin, trimethosulfa. You can, if you suspect mycoplasma and bordetella, then you can use doxycycline, chloramphenicol. In acute infection or when you remove or eliminate primary etiology, antibiotics they are required for around 1 week. If you there is chronic bacterial rhinitis, you need a prolonged antibiotic treatment. How we use antibiotic? We initially start antibiotic for 1 week. If good response occurs, then you use antibiotic for minimum 4 to 6 weeks. If signs they recur after discontinuation, the same antibiotic can be used. If no response after the initial treatment, you have to change the antibiotic. Second nasal disorder is nasal mycosis or fungal infection of the nasal cavity. First one is cryptococcosis. Cryptococcosis is caused by Cryptococcus neoformans. Most commonly, this disease is seen in cats. This organism enters through the respiratory tract. In dogs, clinical signs they are mostly commonly associated with central nervous system. In cats, clinical signs they are associated with the central nervous system, skin, eyes, nasal cavity, or subcut tissue. Lungs they are commonly affected in both species. This organism has thick white capsule. So if you see on cytology, this is the organism. You can see the thick capsule. This is a organism, right? Second fungal disease is aspergillosis caused by Aspergillus fumigatus. This organism is normal inhabitant of nasal cavity. So this mold form of this organism that develops into the fungal plaques or mats. These mats invade the nasal mucosa. So this disease occurs most likely whenever there is any primary disease, other primary disease like neoplasia, foreign body, trauma, prior trauma, immunodeficiency. Most of the aspergillosis cases, you don't observe any underlying disease, so it is seen. You would see the chronic nasal discharge that could be mucopurulent with or without hemorrhage or purely hemorrhagic. You would see the ulceration and depigmentation of external layers and sensitivity to the palpation of bone, facial bone or nasal bones. You can see the nasal discharge, unilateral, bilateral. Systemic aspergillosis is rare but fatal. It is primarily seen in German shepherds. You can see the erosion of external layers. No single test is diagnostic for aspergillosis as its opportunist always rule out other nasal disease. So you can see the on the cytology, right? Fungal hyphae, branching fungal hyphae. Radiographic signs of aspergillosis, you would observe well-defined lucid areas in the nasal cavity and increased radiolucency rostrally. In advanced case of aspergillosis, you observe bone destruction. Generally, you don't find bone destruction in case of fungal infection of the nasal cavity, but in advanced disease, you can observe bone destruction also. You would see the increased fluid opacity. If fluid opacity occurs in the frontal sinus, that may represent the site of infection or maybe due to mucus accumulation, due to obstruction in the drainage. On rhinoscopic, you would see the fungal plaques or erosion of turbinates. If you don't find erosion of turbinate or fungal plaque, that doesn't rule out the aspergillosis. Confirmation is by cytology or culture of material collected by biopsy. Invading organism can, so this aspergillus you can stain with the routine stain, uh, but special staining can be used, right? Very important. Aspergillosis, this disease occurs multifocally, so you need multiple biopsy specimens because this is a possibility that you may skip the sampling from actual place or appropriate place. So this may happen. So that require multiple biopsy specimens. Culture results, they are difficult to interpret because this organism is a normal inhabitant. So if you take swab or culture from it, it is generally growth is generally observed. So there are chances of false positive because organism there that is a part of normal flora in the nasal cavity. Positive culture along with other appropriate signs and diagnostic findings supports your diagnosis. Treatment topical after debridement of plaques, oral itraconazole. If you suspect extension of disease beyond the nasal cavity and frontal sinus, you can use topical enilaconazole tubes twice a day for 7 to 10 days. During 1 hour of infusion, animals were kept anesthetized and caudal nasopharynx external layers were packed. If you suspect frontal sinus involvement, you can do debridement and clotrimazole cream packing. You have to reevaluate 2 to 3 weeks after treatment for non-invasive clotrimazole treatment. Animal is anesthetized and endotracheal tube is passed. Dog, dog positioned in the dorsal convulsive. Uh, Sorry, dog positioned. So what will you do? You position a dog in dorsal recumbency with nose pulled down parallel with the table, and you pass a Foley's catheter through the oral cavity around the soft palate and into the caudal nasopharynx, right? Such that bulb is at the junction of hard and soft palate. Then inflate the bulb and a sponge inserted within the oropharynx, caudal to the balloon and ventral to the soft palate. So these sponge help to hold the balloon in position. And additional sponge are placed around the endotracheal tube to prevent aspiration. Then you pass urinary catheter into the dorsal meatus of the each nasal cavity to a distance midway between the external layers and medial canthus. This is very very important, right? Then small suture placed around across each nares to prevent the balloon migration, and then solution of trimer administered. Each follies checked for filling during initial infusion and then clamped with when clotrimazole begins to drip from the catheter. Solution is viscous, but excessive pressure is not required. Then additional tramadol administered during next hour at rate result in approximately one drop every few seconds from external. After initial 15 minutes, head is tilted slightly to one side and the other for 15 minutes each, and then back into dorsal recumbency. After this hour of contact time, dog rolled into sternal recumbency with the hand hanging over the end of table and nose pointing toward the floor. Catheter removed from the nurse and a chlorotrimazole resulting mucus drain allowed to drain. Then catheter in the nasopharynx should be removed. So this is a process. You pass volleys from the oral cavity into the nasopharynx. Bulb is inflated at the junction of hard and soft palate, and another volleys is passed through external nares and bulb is inflated. Basically, you are blocking anterior and posterior openings so that drug remains inside for longer period. Then infusion catheter or urinary catheter passed and drug is infused through this catheter. So this is the way. Complication of clotrimazole treatment: aspiration pneumonia, meningoencephalitis. Whenever cribriform plate is compromised, uh, clotrimazole and polyethylene glycol, base of carrier of clotrimazole, that makes contact with the brain and it causes meningoencephalite that could be fatal. Integrity of cribriform plate is judged through CT scan or MRI. Another complication is secondary bacterial rhinitis, sensitivity to inhaled irritants. Another disease is nasal mite. Nasal mite is pneumonitis caninum. It is 1 mm in size. Most of the nasal mite infestation they are silent. Important point here is clinical sign of nasal mite. They are very similar to foreign body. You would observe sneezing, pine at the nose, head shaking, reverse sneezing, chronic nasal discharge. Diagnosis of nasal mite through rhinoscopy and retrograde nasal flushing. This might can be located in frontal sinus and caudal nasal cavity also. Treatment: you can use ivermectin at the dose rate of 0.2 mg per kg body weight, subcut repeat after 3 weeks, and you can use salamectin 6 to 24 mg per kg body weight topically over the shoulder every 2 weeks for 3 treatments. Milbemycin can be used. This is a pneumonitis caninum nasal mite. Next disease of nasal cavity is nasal capillariasis. This organism, Capillaria bohemi, cause this disease. This organism is present in the mucosa of nasal cavity and frontal sinus. You would observe mucopurulent nasal discharge, sneezing, with or mucopurulent nasal discharge with or without hemorrhage. How you diagnose nasal capillaria? Based on fecal flotation, you observe double opoculated eggs, or you can do rhinoscopy. You can observe adult worms on rhinoscopic exam. Ivermectin or fenbendazole can be used. These are double operculated eggs. One operculum, second operculum. Nasal polyps. Nasal polyp is a rare condition. So these polyps present animal presented with a chronic nasal discharge with or without hemorrhage. So these polyps they destroy the terminates and bones. So this can be misdiagnosed as neoplasia. Diagnosis of polyps they are based on histologic evaluation of biopsy specimens. Treatment is surgery. Nasal tumors, most of the nasal tumors, they are malignant. In dogs, adenocarcinoma, squamous cell carcinoma, and differentiated carcinoma are observed. In cats, lymphoma and adenocarcinoma are common nasal tumors. Fibrosarcoma and other sarcomas, they are common in both species. Benign nasal tumors, they are adenoma, fibroma, papilloma, and transmissible venereal tumor, TVT. Clinical sign of nasal tumor, tumors they occur in older animals. Generally, they occur in older animals. Nasal discharge is the main complaint, primary complaint in nasal tumors. Nasal discharge can be unilateral, bilateral, but if there is bilateral nasal discharge, discharge is often worse from one nostril. Initially, discharge is unilateral in case of nasal tumor, but later on it becomes bilateral when septum gets destroyed. Sneezing may also occur. As you know, tumors they obstruct the nasal cavity, and they decrease the airflow. And obviously, there would be deformity of facial bone, hard palate, and maxillary dental arcade. If tumor that extends to cranium, that will lead to neurologic signs. If tumor extends to a bony orbit, eye orbit, that will lead to bulging of the eyeball or exophthalmos. Diagnosis of nasal tumors through clinical signs, imaging of the nasal cavity, frontal sinus, rhinoscopy, definitive diagnosis of nasal tumor through histopathology. Uh, Imaging and rhinoscopy reflects soft tissue mass lesions, bone destruction, or diffuse infiltration of mucosa with the cells, either inflammatory cell or neoplastic cells. Very important, biopsy specimen, including tissues from deep within the lesion, should be obtained. Nasal tumors, very important. Nasal tumors, they caused marked inflammatory response of the nasal mucosa, and in some patients there would be fungal or bacterial infection. So cytological diagnosis must be accepted cautiously with the consideration of concurrent inflammation. And these tumors, they cause inflammation and hyperplastic and metastatic changes to the cells. So you have to accept cytologic diagnosis very cautiously, right? Not all cases of neoplasia will be diagnosed on initial evaluation. So you have to repeat these tests: imaging, rhinoscopy, biopsy in 1 to 3 months. CT MRI more accurate and sensitive. So you have to aspirate the lymph nodes, mandibular lymph node, that will tells whether there is localized spreading of disease or not. You have to take chest X-ray to rule out metastasis. You have to evaluate the bone marrow or do abdominal ultrasonography to rule out lymphoma. Treatment: if benign tumor is there, surgery; if malignant, surgery along with radio or chemo. In cats, chemo, radio, both can be used. Radiotherapy reduces the adverse effect of chemotherapy, but it is insufficient if neoplasia involves various organs, other organs. Surgical debulking recommended before ortho radiotherapy. Most of the other malignant nasal tumors, radio is the treatment of choice. Chemotherapy is used where radiotherapy failed or not a viable option. In chemotherapy, you can use cisplatin, carboplatin, multi-agent chemotherapy. You can use piroxicam. Piroxicam is an acid, so you can expect these side effects like GIT ulcer, kidney damage. Another disease is allergic rhinitis. Very important. This is a hypersensitivity response within the nasal cavity and the sinuses to airborne antigens or food allergen may play a role. Clinical sign in allergic rhinitis: sneezing. These signs may worsen may be worse during certain season or in presence of cigarette smoke, or there or after the introduction of kitty litter or new fabric, new perfume, new furniture, any or new cleaning agent in the house. Diagnosis: history, historical relationship between the signs and particular allergen, and then resolution of signs after removal of allergen. Biopsy: if you take nasal biopsy in case of allergy rhinitis, you would see the eosinophilic inflammation. Chronic disease, chronic allergic rhinitis में mixed inflammation मिलेगी, that obscures your diagnosis. On nasal X-ray, you would found increased soft tissue opacity with minimal or no turbinate destruction. Treatment: remove offending allergen, use antihistamines, chlorpheniramine, cetirizine. You can use glucocorticoids. Then next is canine lymphoplasmacytic rhinitis. It's idiopathic chronic rhinitis, sometimes characterized by inflammatory infiltrates seen in nasal biopsy. Neutrophilic inflammation can be seen. Clinically presented as bilateral mucopurulent discharge. You observe no fundoscopic lesion, no lymphadenopathy, no facial or palate deformity. You would observe healthy teeth and gums in this disease. Non-specific findings in lymphoplasmacytic rhinitis is turbinate erosion, mucosal inflammation, mucus accumulation, neutrophilic or mixed inflammation with bacteria on cytology of nasal discharge and lymphoplasmacytic or neutrophilic inflammation on biopsy. Non-specific abnormalities attributable to chronic inflammation such as epithelial hyperplasia and fibrosis. Secondary retinitis or mycoplasma can be identified. Treatment of idiopathic canine lymphoplasmacytic rhinitis. Treat for secondary rhinitis and efforts are made to decrease irritant in the environment. Draining of nasal discharge by humidification of air or instillation of sterile saline into the nasal cavity. Anti-inflammatory response. You can use prednisolone. Gradually taper the dose of prednisolone. If there is no response to prednisolone, you can use other immunosuppressive azathioprine. If signs they worsen with the corticosteroid, you have to discontinue corticosteroid and you can use itraconazole. In severe or non-responsive cases, rhinotomy or turbinectomy can be used.